Statins are the best-selling class of drugs in pharmaceutical history. Tens of millions of people take one every day, trusting it's protecting their heart. Dr. David Brownstein, author of The Statin Disaster, makes a claim that stops people cold. He argues statins provide a real, measurable benefit to only about 1% of the people who take them. Today we're unpacking his argument and what he says is actually driving heart disease instead. Dr. Brownstein is a board-certified family physician and the medical director of the Center for Holistic Medicine in Michigan, with decades of clinical experience treating patients holistically rather than purely pharmaceutically. In The Statin Disaster, he says he set out to write the book specifically because, in his view, most people, including many healthcare professionals, aren't fully equipped to properly evaluate the statistics behind the studies statins are approved and marketed on. That's a bold claim to make about an entire field of medicine. So let's actually look at what he means by it in detail. For decades, the dominant idea in cardiology has been fairly straightforward. High cholesterol, especially LDL cholesterol, contributes to clogged arteries and causes heart attacks, so lowering it with a daily medication should meaningfully lower your risk of a cardiac event. Statins work by blocking an enzyme involved in cholesterol production in the liver, and they do reliably lower cholesterol numbers on a standard lab test, often quite dramatically. Brownstein's argument isn't that statins fail to lower cholesterol. They clearly do that reliably and consistently. His argument is that lowering the number on a lab test isn't automatically the same thing as meaningfully reducing your actual risk of a heart attack for most people, and that cholesterol itself has been unfairly cast as the primary villain in a much more complicated story. This is the statistical core of his book, and it centers on something called number needed to treat, or NNT. Brownstein's point is that when you actually read a favorable statin study's underlying data, not just the summarized headline conclusion most doctors and patients ever see, the relative risk reduction numbers can look genuinely impressive, while the absolute risk reduction underneath them is often quite small. In practical terms, that means a very large number of people have to take an expensive medication for years, carrying all of its potential side effects, in order for a small number of them to receive any measurable protective benefit at all. Brownstein argues that number is close to just 1%, meaning roughly 99% of people taking a statin get essentially no measurable heart attack prevention benefit from it, while still carrying the drug's full risk profile the entire time. He's also pointed to a broader historical timeline as supporting context. Rates of death from cardiovascular disease had already been declining steadily for years before statins came into wide use in the mid-1990s, which he argues undercuts the popular narrative that this specific drug class deserves the primary credit for the improved heart disease outcomes we've seen over the past few decades. In his view, factors like reduced smoking rates, better emergency cardiac care, and other public health shifts likely played a much larger role than the medication itself. If not cholesterol, then what does Brownstein say is actually driving heart disease? His clinical framework points to a different set of underlying drivers entirely: chronic inflammation, ongoing stress, smoking, heavy metal toxicity, low-grade infections, dehydration, and a diet heavy in processed, high-sugar, high-carbohydrate foods. His argument is that the body actually uses cholesterol, including LDL specifically, as part of its natural response to inflammation and ongoing tissue repair, and hormone production more broadly, so aggressively suppressing it with a medication doesn't address whatever underlying inflammatory driver caused the problem in the first place, and may actually interfere with the body's own repair processes along the way. He also connects this directly back to hormone health more broadly, arguing that cholesterol is the essential building block for all of the body's steroid hormones, including estrogen, testosterone, progesterone, and cortisol. So a therapy that suppresses cholesterol production can have real downstream effects on hormone balance throughout the body. This is one of the reasons his book pays particular attention to statin use specifically in women, who he argues are more vulnerable to these hormone-related side effects than the clinical trial populations historically weighted more heavily toward men would suggest. He points out that a substantial share of the original large-scale statin trials enrolled far more men than women, meaning the side effect and benefit profile we generally rely on may not translate cleanly onto female physiology, particularly around perimenopause and menopause, when hormone balance is already shifting on its own. Brownstein's book also catalogs a long list of adverse effects reported through the FDA's Adverse Event Reporting System associated with statin use, including muscle pain, and in some cases more serious muscle damage, cognitive effects like memory problems and brain fog, an increased risk of new onset diabetes, and effects on liver and kidney function. He's also cited commentary from former FDA officials suggesting that only a small fraction of adverse drug reactions generally get reported through official channels at all, which he uses to argue that the visible, documented side effect data likely understates the true real-world picture by a significant margin. It's also worth addressing a question that comes up constantly in the comments on this topic. Does Brownstein think statins never help anyone at all? Not quite. His own writing acknowledges that within that small percentage who do see a measurable benefit, the effect is real, not imaginary. His argument is narrower than a blanket statins do nothing claim. He's specifically skeptical of the way guidelines have expanded over time to recommend statins for increasingly large swaths of the population, including many people with no history of heart disease at all, based on cholesterol numbers alone rather than a fuller picture of someone's actual risk. His concern is less about the drug class existing at all and more about how broadly and reflexively it's being prescribed relative to the actual size of the benefit in most of those prescriptions. There's a related statistical point Brownstein raises that's worth understanding on its own. Newer cholesterol guidelines have progressively lowered the threshold at which a doctor is encouraged to recommend a statin, meaning more people qualify for the medication today than would have a couple of decades ago, even though their underlying individual risk hasn't necessarily changed. Brownstein has pointed out that under some of the more aggressive recent guideline versions, the overwhelming majority of patients seen in a typical general practice would technically qualify for a statin recommendation based on cholesterol numbers alone, a figure he uses to argue that the guidelines themselves have become disconnected from genuinely high-risk, targeted prescribing and have instead drifted toward treating an entire population based on one lab value. It's worth being direct here about where this argument actually sits within medicine as a whole. Brownstein's position is well outside mainstream cardiology guidance, which continues to support statin use, particularly for people who've already had a heart attack or stroke, where the evidence for benefit is generally considered considerably stronger than in lower-risk populations. Most major health organizations don't agree with his 1% framing specifically, and researchers who support statin point to a much larger body of trial data showing meaningful risk reduction, especially among higher-risk patients with existing cardiovascular disease. This is a genuinely contested area of medicine, not a settled one either way, and Brownstein represents one strand of a real, ongoing scientific and statistical debate rather than an uncontested consensus that mainstream medicine simply refuses to acknowledge. Whatever side of this debate you personally land on, Brownstein's underlying challenge is worth sitting with regardless. Are you looking at the actual underlying data behind a given treatment, or just the summarized headline conclusion someone else has already interpreted for you? That's a fair question to ask about any medication you or a family member is taking long term. Subscribe for the next video in this series, where we go deeper into what Brownstein says cholesterol is actually good for in the body. And to be completely clear, never stop taking a prescribed medication, including a statin, without talking to your doctor first. This video is educational only and is not medical advice.